Hello, I'm Andrew Chan. I'm a gastroenterologist at Massachusetts General Hospital, and I would like to speak to you today about the topic of what to recommend to your patients to reduce colorectal cancer risk beyond screening. These are my disclosures. So as gastroenterologists, I think we're all quite familiar with colonoscopy being an effective tool for screening and prevention of colorectal cancer. Many years ago, we performed this large prospective cohort study to actually try to quantify the impact of colonoscopy screening on cancer risk. In two large population-based cohorts of male and female health professionals, we found that colonoscopy was associated with about a 50 to 60% reduced risk of colon cancer. However, there is some challenges with colonoscopy. In particular, we know colonoscopy is more effective for prevention of distal colorectal cancer. We saw in our study that the risk of distal colorectal cancer was reduced by 75%. In contrast, the risk of proximal cancer was only reduced by 25%. This was actually recently corroborated by findings from a randomized trial of colonoscopy called the Nordic trial. And this trial also highlighted some of the challenges we have in relying on colonoscopy alone for prevention. In the Nordic trial, they randomized individuals to an arm in which they were invited for colonoscopy versus usual care in 3 different countries in Northern Europe. What they found was a reduced risk of colon cancer of about 20%, with only a very minimal, non-significant decrease in colorectal cancer mortality. However, the major caveat with this study was that among the individuals that were randomized to an invitation for colonoscopy, only 42% of individuals actually followed through with the invitation and underwent a colonoscopy. As a result, if you looked instead at the data per protocol, in which you actually looked only at people who fulfilled the entire protocol and actually underwent a colonoscopy, the risk reduction was more substantial, more in keeping with the findings we had back in 2013 of about a 30% reduction in colorectal cancer incidence and about a 50% reduction in colorectal cancer mortality. So this highlights the fact that we do have challenges with getting patients to adhere to colonoscopy, and of course, resource constraints and whom can be able to access a colonoscopy readily. Of course, these findings led to a lot of consternation in the lay press. If you recall some of the headlines at that time, there was declarations that colon cancer screening was actually a big failure and a waste of time. Of course, that nuance of the fact that many of the people that were invited for colonoscopy didn't follow through didn't make it into the media reports. But we still really do feel colonoscopy is an important linchpin for our preventive strategies. But now that we know there are limitations to colonoscopy, I think as gastroenterologists, we also need to be quite familiar with other possibilities for prevention. In particular, I think we need to be familiar with the potential of using diet and lifestyle prevention methods, and also potentially novel methods for prevention, such as chemoprevention with repurposing of pharmacological agents like aspirin. And that's what I will cover in this talk to be able to give you some practical advice that you can offer your patients. As many of you know, many of your patients will ask you, what is it that I can do to prevent colorectal cancer? This may even happen after you have a patient undergo colonoscopy in which you find polyps, and they're concerned about the risk of recurrent polyps. So let me just briefly review what we know about established lifestyle and dietary risk factors for colorectal cancer. This is a very sort of bird's eye view of risk factors in terms of what, and I think what I show here is really a summary of decades of epidemiological studies, which have really supported these as being the primary risk factors for colorectal cancer. And among cancers, colorectal cancer is the one cancer type for whom lifestyle and diet seem to be the most important in terms of predicting risk. So let's go through these one by one. First, we know that there is a strong linkage between moderate to heavy alcohol use and colorectal cancer. There's also a link between heavy smoking history and colorectal cancer, a link between being overweight or obese and colorectal cancer, and a lifestyle in which there is a lack of regular physical activity and risk of colorectal cancer. From the standpoint of diet, we know that a diet low in fruits and vegetables is associated with the risk of colorectal cancer, a diet low in whole grains. And a diet high in processed meats and a diet high in red meats is associated with the risk of colorectal cancer. So I would say that these are sort of the key risk factors to consider for your patients when they ask that key question of you, what is it that I can do to actually reduce my risk of developing cancer in the future? Now let's quantify this a little bit more. And I think the best sort of summary of the quantifiable risk that's associated with these risk factors was in this review back in 2019. This was a review which really put together, many, many decades of epidemiological studies, particularly prospective cohort studies, which is the best sort of epidemiological evidence associating lifestyle and diet with risk. And they nicely summarize the risk factors here on the left, and also provided a brief summary of the level of evidence that supports its association, and a rough idea of the magnitude of risk based upon a unit increase in each of these risk factors. So this will be available in your syllabus, but to suffice it to say that there is quantifiable things you can do to actually reduce your colorectal cancer risk. Of course, these numbers and hazard ratios are sometimes very difficult to actually convey to a patient. So I would like to also think about lifestyle and diet as sort of an amalgamation of risk factors that can be used to actually counsel patients to kind of think about overall lifestyle as a way to reduce cancer risk, in which we can provide a more quantifiable estimate that's easier to communicate to patients. So what is the best way to quantify the contribution of overall lifestyle to risk? Well, as I mentioned, we know a lot about individual risk factors, and these come again from a wealth of epidemiological studies. But can we actually put together these healthy lifestyle factors together in models to actually quantify lifestyle risk and use that model of lifestyle risk to actually counsel patients as to whether they can reduce their individual risk just through lifestyle modification, and also using those models to help us define who's at high risk and low risk for colorectal cancer for further interventions, including more intensive screening. So let's take you through these risk factors and how we've studied them in our research group over the years. So our research group has been working with 3 different population-based cohort studies that are based here at Harvard and Harvard School of Public Health. The Nurses' Health Study, which is a female cohort of 121,700 female registered nurses enrolled across the US. The Nurses' Health Study 2, a younger cohort of nurses, 116,000 of whom were enrolled in 1989. And finally, the Health Professionals Follow-Up Study, which is a parallel cohort of male health professionals that was enrolled in a very similar study in 1986. And what's been very important about these particular studies is that they've given us a wealth of lifestyle data every 2 years since the 1970s, 80s, and 90s. And over time, they've also given us access to their medical records so that we can ascertain diagnoses of adenomas and colon cancer, and also review endoscopy reports to know what has been found on colonoscopy. So this is an unprecedented source of data for us to understand the linkages between diet, lifestyle, and cancer and adenoma risk. So we've really focused on several lifestyle factors in our studies, and these are the ones that, again, shake out to be the most critical for colon cancer risk. And that includes smoking, body mass index, physical activity, alcohol intake, and various components of healthy diet, as I mentioned before, including red meat intake of whole grains, dietary fiber, dairy products, and calcium supplements. So how do we actually use this to actually help us understand the quantifiable impact of lifestyle and diet on cancer risk? So first, I want to mention that with these different risk factors that we've looked at, we've developed a series of risk models that allow us to compute a lifestyle and diet colorectal cancer risk score, with the risk score of 6 to 8, or meaning that you have 6 to 8 cancer risk factors that put you at higher risk in terms of lifestyle and diet for colorectal cancer. Individuals that have only 0 to 2 colorectal cancer risk scores are those individuals that have the lowest proportion of modifiable lifestyle and dietary factors. And as you can see here, the 10-year cumulative incidence of colorectal cancer rises stepwise as you increase the number of colorectal cancer risk score points that you get. In addition, you also see an increase stepwise in 10-year cumulative mortality from colorectal cancer with increasing colorectal cancer risk score. Importantly, however, we also note that in addition to us being able to quantify risk by risk score, we also see that there is an impact of screening on risk, regardless of risk score. So even those individuals that have been screened or unscreened can have an appreciable impact on their risk of colorectal cancer by being screened here in the blue or if they're non-screened here in the red. So definitely there's an impact of screening in addition to lifestyle on risk. Put another way, though, we also know that lifestyle risk may be associated with colorectal cancer incidence, even independent of screening. This is a recent analysis we did of our health professionals that we presented at DDW just last month. And what we found is that if we compare people who are considered high risk by lifestyle compared to medium risk at lifestyle or low risk lifestyle, that the people with a low risk lifestyle have a 0.31 hazard ratio for colorectal cancer compared to those in the high risk category. And these were among people that do not have any history of screening. However, even among people who do screen and have had a negative colonoscopy, there's still a substantially reduced risk of colon cancer among people who've had a low risk score. So those people that were at low risk and had a negative colonoscopy had an 80% reduction in risk of colon cancer compared to people that were at high risk that did not have any screening. Can we also quantify the population attributable risk of lifestyle with cancer risk in comparison to endoscopy? So we conducted this analysis back in 2021 using lifestyle and screening data and found again that there was an association of healthy lifestyle score with colorectal cancer in both people who are screened and unscreened, again, with the risk of colorectal cancer being highest among individuals that have a poor lifestyle or are unscreened compared to those that have a nice, healthy lifestyle that are screened. If we actually look at it from the standpoint of population attributable risk, this is an estimate of the proportion of cancers that can be prevented by a preventive intervention. We see that endoscopic screening alone can be predicted to reduce about 32% of cases of colorectal cancer over time. If you add lifestyle, you actually see that population attributable risk increase substantially, with the population attributable risk being up to 61% reduced if people undergo both screening and healthy lifestyle. The impact of screening and healthy lifestyle seems to be most pronounced for cancers of the proximal colon, which are seen here in blue. Those in the highest category of both screening and lifestyle score, for example, have a substantially different risk of developing colorectal cancer compared to those who only undergo screening. As you can see that there is quite a difference here compared to the two categories here for distal colorectal cancer. Can we also use risk-based models and risk that's attributable to lifestyle and diet to actually predict when is the best time for us to start screening? So in this study, we actually looked at that question by examining our entire cohort of participants. If you look at our participants here in the green, across all participants, if we initiate screening at age 45, as is currently recommended, we would expect the cumulative incidence of colorectal cancer over 10 years to be 0.47. But actually, if you look according to individuals' risk-based scores, those individuals at high risk for colorectal cancer by lifestyle who have a score of 6 to 8, in order for us to have screening achieve a 10-year cumulative incidence of colorectal cancer, similar to what you would be achieving if you started screening at 45, you would have to start screening at age 38. In contrast, if you had a low lifestyle risk score and therefore were at very low risk of developing colorectal cancer by lifestyle, you actually could initiate screening much later, at the age of 51, to achieve a 10-year cumulative incidence rate of colorectal cancer, similar to starting at the population average of 45. So about a 12 to 13-year difference in which lifestyle can make a difference as to when is the optimal time to screen. Lifestyle risk models can also predict optimal screening interval after you have a negative colonoscopy. So that patient who you've just had done a colonoscopy on, and if the screening is negative, we routinely recommend that you come back in 10 years by guidelines. But if you actually account for their baseline risk and based on their lifestyle, you actually could predict that they could come back for an optimal screen at a very different time frame than 10 years. So when we divided up the cohort into those that are high lifestyle risk, medium lifestyle risk, or low risk, what you find is that in order to achieve a incidence of colorectal cancer at 10 years that you would see in the high risk category, you could actually postpone screening instead of repeat screening at 10. If we repeated screening at 10 years for the high risk group, you could actually postpone repeating screening for the medium risk group at 16 years. And you could actually defer a follow-up colonoscopy to 25 years among people that have a low lifestyle score. So risk-based model can actually help you predict how urgent is it for you to have a person come back for a colonoscopy after a negative screen. Finally, looking at lifestyle with respect to cancer risk after polypectomy, we used again our lifestyle score modeling to actually determine the incidence of colorectal cancer after someone has a polypectomy. And what you see here is that people with the healthiest lifestyle had about a 50% reduced risk of colorectal cancer compared to those with the unhealthiest lifestyle after a polypectomy. So after that person has an adenoma removed, it's still quite important for us as clinicians to advise those patients to do what they can to keep a lean body weight, minimize smoking, stay physically active, minimize alcohol intake, and eat a healthy diet. So now let's turn to other models of prevention, other ways to actually potentially prevent colorectal cancer beyond screening. I do want to focus on aspirin because that is the area for which there is the strongest evidence to support its effect as a chemopreventive agent. To summarize, there's a wealth of data to support aspirin as a preventive agent for colorectal cancer. There have been over 100 case control and cohort studies that have shown that people who take aspirin have a reduced risk of cancer. In addition, there have been 5 separate randomized trials of aspirin in which people who take aspirin and have a history of either adenoma or cancer have a reduced risk of a recurrent adenoma. There have been also more than 50 cardiovascular prevention randomized trials in which the trial investigators have linked those data with cancer outcomes, and they found individuals originally randomized to aspirin also had a reduced risk of colorectal cancer. There's also long-term data from the CAP2 randomized trial of aspirin in patients with Lynch syndrome. In this cohort, after long-term follow-up, they also had a 30 to 40% reduced risk of colon cancer. And finally, we know from the Women's Health Study, the largest primary prevention study of aspirin ever conducted, that aspirin in this cohort reduced the risk of colorectal cancer after 10 years by 30%. This led to a milestone recommendation in 2016 by the U.S. Preventative Services Task Force that low-dose aspirin be used for the primary prevention of cardiovascular disease and colorectal cancer. So this was an additional rationale to recommend aspirin use for people who might be at modest cardiovascular risk. This led to a lot of enthusiasm and excitement in the cancer prevention community and even in the lay press. As you can see here, there was a declaration that aspirin in a first was a recommended form of cancer prevention that had not been used in the past. But things changed in 2021 and 22 when the U.S. Preventative Services Task Force revisited their guidelines, and they actually came out against the use of aspirin for colorectal cancer incidence or mortality, concluding that the evidence was inadequate. This, of course, also led to a lot of media attention and confusion. Again, this now created a situation where people weren't sure what data to believe. And now we're thinking about whether aspirin should be recommended even for primary prevention of cardiovascular disease. Now, why did the USPSTF take this action? Well, it's largely due to the fact that there was a randomized trial of aspirin among older adults that was released that showed a very surprising finding. So the ESPRIT study is the aspirin and reducing events in the elderly study, which randomized 19,000 participants over the age of 70 in the US and Australia and 65 in US minorities. They were randomized to either 100 milligrams of aspirin per day or placebo and followed for 4.7 years, with the primary outcome being death from any cause, dementia, or persistent physical disability. And what was found was extremely surprising. First of all, the primary endpoint was null. There was no effect on death, primary disability, or dementia. But what was potentially very surprising was that in contrast to all prior studies, individuals that took aspirin actually had an excess risk of death with a hazard ratio of 1.31. This was very surprising, again, because of all the prior data, which had showed quite consistently that aspirin was associated with lower risk of cancer death. But there's several caveats here. One is that I'd like to mention that this separation of the curves between aspirin and placebo started to occur very early after only 3 years of follow-up. So keeping that in mind, how do we then explain these findings relative to prior findings? Well, first, I want to emphasize that ESPRIT was not a test of cancer incidence. It was a primary study done with a composite endpoint of disability, dementia, and death, and cancer mortality. In addition, there was a very short treatment duration. As you can see, there were only patients on study for about 4.7 years, so the follow-up was quite short. And the last was it was a very highly selected population. So looking at this a little bit more detail, when we think about it being not a test of cancer incidence, that's very important. And let me tell you why. I was fortunate to be able to work with the ESPRIT team after the primary results were released to actually look at the effect of aspirin, not just on cancer death, but on cancer incidence. So in this analysis, as you can see here, the primary result was an overall increase in cancer-related mortality. And this occurred across different tumor types. But when we actually looked at cancer incidence in a follow-up analysis 2 years later, we found that aspirin was not associated with any increased risk of incident cancer, but it was associated only with an increased risk in stage 4 cancer. So what it suggests is that aspirin seems to have an effect on later stages of disease. And given that this effect was seen after only 3 years of treatment, this suggests that maybe aspirin has an effect on cancers or early tumors that may already be prevalent in the population when they were first started on the study. We know that aspirin has a really important effect on prevention of early lesions like polyps. This is a summary of the 5 randomized trials I mentioned, in which there's a very consistent benefit, about 15 to 20% across different RCTs, in which there's a preventive effect of aspirin on polyps. So is it possible that there is this effect on preventing polyps, which is an early stage lesion, and maybe a challenging and more harmful effect in promoting cancer once it's already developed? Finally, we also should think about the treatment duration. As I mentioned, all prior data suggests that aspirin doesn't have effect until after at least 10 years of follow-up. This is data from the Women's Health Study, which shows that the survival curves only start to diverge after 10 years. In the Lynch population, there was also no benefit of aspirin until 10 years after treatment, as you see here. So it may be that the effect of aspirin on cancer risk has still not really emerged yet in ESPRIT, and that we need to have longer-term follow-up with the cohort to know if there is a legacy effect of aspirin treatment. In addition, finally, I do want to mention this is a very highly selected population. The ESPRIT population was largely over the age of 70, and these were people that largely were never using aspirin before the age of 70. Is it possible that starting aspirin too late may actually be detrimental instead of helpful? And this has a strong biological rationale. We know that cancers that develop early in life may be somewhat different from cancers that arise later in life. In addition, we also know that where the types of lesions that are needing to be interrupted before cancer develops may be particularly prevalent early in the life course. So you can imagine many of the early changes in the colonic mucosa that leads to adenoma may occur earlier here and may be less of an issue over here, in which aspirin may actually cause tumors to grow or metastasize. This is actually supported by other randomized trial data. This is the Japanese prevention of atherosclerosis in diabetics. They found among people over the age of 65, there was no difference in the effect of aspirin on cancer risk, but for younger people, there was an effect of aspirin on cancer risk. We also saw this in epidemiological cohort in the Nurses' Health Study, Health Professionals Follow-Up cohort. We found that the age of initiation of aspirin was important, that aspirin users who initiated the drug before the age of 70 had a reduced risk of colon cancer. If you initiated aspirin at older ages, after the age of 70, there was no appreciable decrease in risk of cancer. So I think what this suggests is that there might be a differential effect of aspirin according to age. And this actually might be quite interesting for us to think about, given what we know about the prevalence of early onset colorectal cancer, which is rising rapidly in incidence. What we see here in this study, which we conducted in the Nurses' Health Study too, is that among this cohort of women who underwent lower endoscopy, that aspirin use and NSAID use was associated with a particularly low risk of developing early onset adenoma or a polyp before the age of 50. So given what we know about the fact that we cannot screen everybody under the age of 45 for colon cancer, this may be a potential preventive option for people at higher risk. What about aspirin and other GI cancers? Well, there's very promising data also that aspirin could reduce risk of hepatocellular cancer. This was a study led by Tracy Simon, a gastroenterologist and hepatologist at MGH, and she found that aspirin use was associated with a lower risk of both HCCs in women and men in the Nurses' Health study. And she also corroborated this finding in a Swedish cohort in which individuals with a history of chronic hepatitis B and C who used aspirin also had a low risk of HCC, as you can see here in the blue compared to the yellow. So this is observational epidemiological data. Is there actually randomized trial evidence to support the fact that aspirin actually may reduce risk of HCC? Well, we recently completed a randomized trial of aspirin in individuals at high risk of HCC, specifically those people with metabolic dysfunction associated steatotic liver disease, or formerly known as NAFLD. Again, many of you know that these people, 30% of adults have this condition, and 1/3 develop steatohepatitis and fibrosis, and still a large group of these people who develop fibrosis and cirrhosis can develop liver cancer. So we conducted a randomized trial of aspirin and MASLD here at MGH. We randomized 80 patients with MASLD 1-to-1 to receive either aspirin, 81 milligrams, or placebo once daily for 6 months. And this was a trial led by Tracy Simon that was just recently published in JAMA in just a couple of months ago. The primary endpoint was the change in baseline to month 6 hepatic fat fraction assessed by magnetic resonance spectroscopy. And secondary endpoints was also change in baseline to month 6 MRI protein density fat fraction, among other endpoints. And we did see a very promising result. Among individuals that were taking aspirin, there was an absolute decrease in hepatic fat fraction compared to placebo in both intention to treat and per protocol studies, such that the overall difference from placebo was about 10% reduction in hepatic fat fraction in just a 6-month period. In terms of the secondary endpoint, there was also a relative decrease in hepatic fat fraction from baseline in both intention to treat and baseline. As you can see here, there was a 59% reduction in risk of relative hepatic fat fraction in patients that were treated with aspirin compared to placebo. So this gives us early evidence that potentially aspirin is doing something physiologically important in patients with MASLD that eventually are at higher risk of developing hepatocellular cancer. What about other cancers? Well, I do want to point out that there are randomized trial data to support the use of aspirin and high-dose PPI in patients with Barrett's esophagus. This was a very large study called ASPECT conducted in the UK. And what they found in this study was that individuals that were taking a high-dose PPI and aspirin, seen here in the red, had a particularly longer time to the development of esophageal cancer, high-grade dysplasia, or death. So people taking this combination therapy did seem to have reduced risk of these difficult endpoints in patients with baseline Barrett's esophagus. Of course, the concern about aspirin has always been GI bleeding. We certainly understand that to be an issue with aspirin treatment. But I do want to point out that there is contemporary data now that suggests that maybe aspirin-related GI bleeding is less of an issue than we might have surmised from prior data. This was a recent study of Helicobacter pylori eradication among a large UK cohort of individuals that were taking aspirin on a regular basis for cardiovascular protection. So the primary endpoint was actually the primary intervention was eradication of H. pylori compared to control, and they did show that people who had been eradicated for H. pylori did have a lower risk of developing a bleeding ulcer compared to those that were not eradicated. What was important, though, from this study was that this was a study of over 5,000 individuals. And within this, we only saw 18 events in people that were on eradication therapy, or 26 events. So the total number of ulcer bleeds in a cohort of over 5,000 people was really quite small. And if you actually look at the Kaplan-Meier curves for ulcer bleeding, you can see here that in terms of absolute numbers of bleeds, the actual curves are really difficult to distinguish from each other. So this led the investigators to conclude that the low background rate of ulcer bleeding in the trial, together with H. pylori eradication and aspirin suppression, should suggest that maybe we should be a little bit more liberal about our use of the drug. That was very thought-provoking, and so I would leave you with this summary in terms of who we should treat with aspirin. So I think based on the CAP2 study, the population of patients with Lynch would be a very good candidate to treat. I would also consider treating patients with a prior history of adenoma in whom there's been a detailed discussion of risks and benefits. Generally, I do recommend low dose, although the data about dose is still quite controversial. There's actually a study currently ongoing in the Lynch population to see if low dose aspirin is as effective as taking standard dose aspirin or high dose aspirin. In addition, given the effect of aspirin on young patients, it should definitely be considered for people who are worried about early onset colon cancer. In addition, aspirin could be considered for people who are unable to undergo screening or surveillance, patients potentially with MASLD, patients potentially with Barrett's esophagus. But all of this, I think, is with a caveat that it does require clinical judgment and evidence is not perfect. I do want to mention very briefly some other pharmacological agents that have been tested. Celecoxib and rofecoxib have been tested in adenoma prevention studies. And as you can see from these trials, across the board, they reduce risk of recurrent polyps as well, and maybe to a little bit stronger effect than aspirin. But the problem with these drugs is that they also were the same trials that elucidated that there was an increased risk of cardiovascular events associated with taking celecoxib compared to placebo. So currently, this is not recommended in routine prevention, particularly for patients at risk for cardiovascular events. There's also data looking at the combination of an NSAID, sulindac, with erlotinib, an EGFR inhibitor, in patients with familial adenomatous polyposis. In this randomized trial, it was shown that people that were treated with this combination treatment did have lower risk of polyps in the duodenum, and also low risk of polyps in the colon, and also their ileal pouches, with a caveat that this does increase the risk of rashes, mucositis, and diarrhea. However, there seems to be also a decreased risk of recurrent adenoma with this combination therapy in a very small clinical trial that was conducted back in 2018, although there are concerns that this agent may be associated with ototoxicity and cardiovascular events, so it's certainly not routinely recommended at this time. Is there a recommendation to use this across the board in FAP patients? Well, there was a study in the New England Journal of Medicine back in 2020 that looked at the effect of combining a DFMO agent with sulindac on risk of progression in people with FAP. And this was progression to surgery or to other endpoints. And they found that there was a non-significant benefit to taking these agents, either in combination or compared with each other. Just to briefly review some other promising agents, there have been data looking at estrogen and progestin. It seems to reduce cancer risk, and this was found in the Women's Health Initiative. But the caveat was that there's an association of these hormones with cardiovascular events, and also a possibility that there could be a signal for actually an association with advanced colon cancer. There is some intriguing data that metformin may reduce the risk of adenomas by about 40% in a very small study, but this again needs to be corroborated by larger studies. And also there is some intriguing data looking at berberine, which is a Chinese dietary supplement, which shows a lower risk of recurrent adenoma compared to those who were on placebo. What's been established to be ineffective has been folate, antioxidants, and fiber supplements. So although fiber in the diet seems to be associated, at least when epidemiological studies, with low risk of cancer, recommending supplements to your patients does not seem to be effective. Of course, these are limited studies, and potentially there may be some nuance as to whether you might need to have a certain level of fiber deficiency before you actually see a benefit from taking a fiber supplement. More controversial data exists for calcium. There have been 2 conflicting studies showing a lower incidence of polyps with calcium intake. One study showed a benefit, and one showed no benefit in combination with vitamin D. There's also controversy around fish oil. A large clinical trial of fish oil and aspirin, a 2x2 factorial study, showed no benefit of EPA or aspirin, which was a bit surprising, although aspirin did seem to reduce the risk of number of adenomas per participant, even though it didn't reduce the number of individuals with recurrent adenoma. So in summary, I hope what I've been able to share with you today is the high unmet need for colorectal cancer prevention beyond screening, that there is an important link between diet and lifestyle and cancer risk, such that it should be a priority for us to recommend primary prevention interventions for our patients, and also potentially use lifestyle and diet to help us risk stratify for screening interventions, in particular for screening interval for colonoscopy, and also maybe in the future for deciding who should be targeted for non-invasive modalities for screening versus colonoscopy screening. There's overwhelming evidence supporting a benefit of aspirin on colon cancer, but the new trial data shows that we need to consider both the age and timing of use, and highlight that there is a low risk of GI bleeding. Aspirin seems to reduce risk of fibrosis in MASLD, supporting epidemiological evidence of aspirin's association with reduced HCC risk. And aspirin also and high-dose PPI seems to reduce risk of high-grade dysplasia, cancer, and death in patients with Barrett's. Other effective agents do have drawbacks: celecoxib, solondecrolatinib, estrogen, progestin, solondec, and DFMO. All are things that have been tested but do have side effects that are worrisome. Calcium and fish oil are safe, but data are conflicting as to whether they're going to really work. And I think most data now suggests that they're not terribly effective. Folate appears ineffective in a population that actually has sufficient folate in their diet, and further data are needed on high-dose vitamin D, statins, and metformin. And with that, I thank you for your attention. I look forward to the questions in the panel at the end.